Good evening, everybody. Welcome to the fourth and final webinar from the four-part series for the UK Periprosthetic Joint Infection Group. The UKPJI group, as I'm sure most people know by now, was set up following the International Consensus meeting in Philadelphia in 2019, which many of the founder members of the UKPJI group had contributed to and attended. And the UK group was then set up off the back of that to try and manage some of the decisions made and how they might best apply to UK practice. Unfortunately, as I'm sure you know, earlier in the year, the Glasgow conference had to be cancelled due to COVID, and the 4 webinars were set up. There's been some fantastic speakers over the 4 seminars so far, and we've got another 2 excellent speakers tonight. This is the 4th and final, just to put a pitch out there to everybody that the Glasgow conference will be held face-to-face in 2022, all things being equal, and it's going to be held on the 1st of April 2022. So do sign up at ukpji.com once the access is open. So without further ado, I'll hand you on to my colleague Sanjeev to open proceedings.
Hey, good evening, everybody. Nice to see you guys. Today, this is the 4th webinar. So I would like to introduce Professor Meek, who is my colleague. He trained in Glasgow and subsequently completed his MD at Glasgow University. He trained in Vancouver in adult reconstruction, following which he got appointed in Glasgow in 2003. He has got specialist interest in hip reconstructive orthoplasty surgery, and he has participated at designing this as a regional center for dealing with complex hip revision, including periprosthetic joint infections. He has been awarded the British Hip Society and American Hip Society Traveling Fellowship, BOE ABC Fellowship, and he is a hip specialty editor for Bone and Joint Journal, and big role in British Hip Society. We're looking at coming presidency at some point. So without further delay, I would like to request Dominic to start the proceedings.
Okay. Thanks very much, Sanjeev. So DAIR, it's really, as we all know, is the debridement, the antibiotics as a treatment, and trying to implant, retain in order to keep the function of the patient that we've done the arthroplasty in. So how do we optimize these, the care of this? Well, is it a problem in the first place? Well, this is actually just from the Scottish Arthroplasty Project, and it shows that infection, in terms of periprosthetic joint infection, has not increased over the last 15 years, at least up to COVID, that is. But what has happened is that there's been a doubling in the numbers of arthroplasty performed. So once we get back over the COVID, we will be getting more periprosthetic joint infections, and we will have a growing problem how to manage them. And particularly since a lot of the post-COVID patients are less fit and higher BMIs, it's a problem that we do need to deal with. And are we winning the war against periprosthetic joint infection? Well, this is a nice summary by Javid Parvizi, who's obviously a world expert in periprosthetic joint infection. And interesting enough, despite all our novel techniques, there's been no decrease in periprosthetic joint infection over the last 10 years. So these bugs are smart. They have various ways to communicate with each other, and the biofilm, we are still not managing to treat that in a way that has decreased the numbers and the incidence. So what about, when did we first start doing DAIR procedures? We can actually go back to Coventry, actually described it back in 1975. Complications of a fulminating infection or hematoma with potential infection. And this was something to be treated with antibiotics and debridement with the components left in place. Whereas if there was a long infection, you had to remove the components. So it's been around the idea and concept of this for quite some time. And the historical results, if we go through them, we can see that there's quite a varied variety, ranging from 14% to 100%. Now, the 100% indeed was only 3 cases, followed for a very short time. So I wouldn't be too excited by that one particular one. So if you start with the 14% one, This was actually from the Mayo Clinic. Back in 1998, they reported this. It was 42 patients. And indeed, they only had a 14% success with this. And quite a few of them are actually still on antibiotics after this. So I suppose that brings us to the first question that I'm going to ask of the audience. And that's if you have something that hasn't worked first, should you try repeated DAIR procedures, i.e. 2 bites at the cherry in order to try and increase your success rate? So if we can just ask everyone to answer yes or no. 45% of you think yes, so that's very interesting. So in fact, there's no real evidence that repeated DAIRs are effective. This was the Mayo group did use this as a technique. They found it actually was quite expensive and time consuming, and it appeared that really, if you did a very thorough debridement in the first place, that wasn't as a particular disadvantage in the results that they got from that. So I think double DAIR is something that has been popularized in various groups. Some people promote it, but overall not something to be recommended. And this is where, well, how do you improve your results? Well, this was a key paper that came out demonstrating that it was the exchange of components. Anything that's modular, you have to change. And this was demonstrated a much lower failure rate of only 28% versus the 44% if they left some of the implants there. So this is one of the first key things you have to understand about a DAIR is anything that's exchangeable, you should exchange it. So as your patient comes in as an emergency to you, I want you to answer me whether you think that you should be waiting for cultures and sensitivities and the next MDT meeting to discuss this patient prior to doing your DAIR, or will you go for targeted antibiotics or will you just go as soon as possible to do the DAIR with a broad spectrum cover? So if you can answer either one, that you want to wait for the MDT, or two, that you think the DAIR should be performed as soon as it's timely possible and start with broad antibiotics. So majority of you are saying that you would go early, which I think is a very reasonable approach. Obviously, if you can get a timely aspirate, that would be useful, but you shouldn't delay the overall procedure for that. And this is a nice summary that came from Hamish Simpson and Paul Gaston in Edinburgh. And they looked at a review of all the cohort studies over the last few years. And there's 3 things I think you could take home from this review. First of all, we have improved. We've gone from an average pre-2000 of less than 50% success up to coming on for 80% success in the last few years. So there has been an improvement. And what was that associated with? Well, again, they showed that modular components exchanged resulted in a better result of getting rid of the infection. But the other key factor they found was time to surgery. And that's why you shouldn't wait for, if you have a fortnightly MDT meeting for infection, you mustn't wait for that. You must go ahead, do the DAIR procedure, get the samples, and then discuss it at your MDT afterwards. Because they noted that if your time of symptom onset was less than 7 days, that was significantly associated with a more successful result. And you can see this in the graph down here. Here we are at 5 days, going up towards 80%, 100% success. If you're over 3 weeks, you're getting a much lower success rate down to 20%. So it's key to do early intervention surgically. Never do it arthroscopically. It has no role, even in the knee, it's been shown to have no role, and it certainly has no role in the hip, unless perhaps a very dire septic patient who you're actually just doing a washout rather than dealing with a proper DAIR. So at that point, I'm going to ask you, if you're when is it too late to perform a DAIR procedure post-operatively? Do you think it's 3 weeks after the operation, 6 weeks? Or do you think that you can wait up to, if it was even 12 weeks post the operation? I think we're also putting in a question is, do you think that there's actually a difference between using a cemented hip replacement and a cementless hip replacement. So if we look at that, most people think that there's not a difference depending on how the fixation is, which is interesting. And you're fairly spread on your time. Some people, a third of you think that it's okay to wait to 12 weeks. Majority think 6 weeks, and a few think it's 3 weeks is the limit. So that's very useful, thanks. So if we actually look at what was discussed at the International Consensus Meeting of Periprosthetic Joint Infection, what we found was that the early postoperative infections that occur within 3 months of the index operation can still be operated on if it's only 3 weeks of symptoms. So it's really the initial symptoms that is the key to when you operate and when it will fail. So you can go up to 3 months post-operatively, and that was a decision that they made there. Obviously, the results might be slightly worse, but you have that option. Differences is in the hematogenous infection, where that's actually come from another source into the hip. Really, again, obviously, it's entirely related to when the symptoms developed, and you have a 3-week interval beyond which you're not going to have success dealing with hematogenous infection. Obviously, there's some types of microorganisms that are favorable and are easier to treat. Others have poor outcomes, but you may not have the time to actually work that out at the time of the operation when you perform the DAIR, but that will be able to advise the patient subsequently of the likely success of the procedure. And then it comes to who should be doing this operation. So I'm going to ask you, should DAIR be performed at the index hospital site? And you can either answer yes or no for that. Interesting. It's well, 2/3 of you think it should be performed at the hospital site, but a third of you think that that's not the case, which again is interesting. The reason that you would possibly consider doing it at the initial site is that if you are modularly changing the components, your hospital will have those components. Whereas it's diverted to another hospital with a different company, it may well result in them having to undergo a revision rather than a DAIR procedure. And indeed, the British Hip Society guidelines that are being performed are suggesting that an index site hospital that performs hip arthroplasty should have the skill set in order to provide a DAIR service. So that's what's regarded as the gold standard if you perform hip arthroplasty surgery nowadays. So what that takes us on to the technical aspects of the DAIR. It is an incision and drainage for sure, but you need to preoperatively optimize the patient. It's not something to be done in the middle of the night. You need a big incision in order to visualize and thoroughly debride all the infected material. And you need to take 5 samples of tissue using a sampling kit. These are individually wrapped scalpels and forceps. And you should make sure that your hospital has those available for taking those 5 samples. And in addition, take an aspirate of any fluid that's present. Copious lavage, 9 liters to the joint. And if necessary, exchange the components that are modular if you have to. Well, you will want to. And this was a very 90% agreement, very strong consensus that this was the technique you should employ. So as I say, 5 tissues, 1 fluid, implant interfaces. And I emphasize to you that consider cemented components as modular. It's easy to tap out a stem, and it's easy to take out a cemented cup and put a new one in if necessary. And obviously the polyethylene is the component that retains the biofilm at the highest rate. So high debridement of all the skin, any sinuses, inflammatory tissue, right down to the capsule, all the synovial, a thorough synovectomy has to be performed. And that brings me on to, would you tend to use adjuvant antibiotics loaded locally into the tissues round about it? So these are the ones that examples are Ceramint, Stimulan, or DAC, the coating of antibacterial antibiotic. So yes, the majority of you are using adjuvant antibiotics, so good. So the technique to continue, you want to start your antibiotics with a broad spectrum, the vancomycin, gentamicin combination, but you want to discuss this as soon as you can with your microbiologist and your infectious diseases consultant, because you want to be able to narrow that down in due course. Often you'll add in rifampicin, it's fairly standard stalwart to increase any biofilm penetration by the antibiotics that you use. Interesting enough, the use of these bioresorbable antibiotic carriers don't have any high level evidence to support them as yet, but I'm sure that will come along when we get more evidence coming from the BAJIR registry, etc., where we'll see, we can tease out whether that is of use. Chlorhexidine washout, however, does have in the literature support for its use. So you should wash out the wound and the skin edges as you're closing up with chlorhexidine. And if this fails with DAIR, don't repeat. That's the take-home message. So who's not suitable for DAIR? I put question mark around sinus because obviously a leaking wound connected to a cavity is a sinus, and it's a relative contraindication, because if you're going to these patients early on, obviously mature sinus is something different, but an early one I don't think you should be worried about. Obviously the implants are loose, you're going to have to exchange them. Fungus should be treated with a two-stage revision, which is why you don't do a DAIR in them, and obviously multiple resistant organisms. Those who are immune compromised is a relative indication, contraindication. They're likely to do poorly no matter what form of treatment you perform on them. So in some cases, an appropriate DAIR, and if you subsequently have to do suppressive antibiotics, may not be a terrible outcome for a very immune and frail patient. When you're actually assessing these patients, there's a couple of scores that have been used. The CLIC score is based on chronic renal failure, liver cirrhosis, whether there was a fracture, and interesting enough, whether it was a cemented prosthesis. And I just wonder whether this was due to the fact that they didn't regard cemented prostheses as modular, and also a very high CRP. And basically, these were all assigned scores. If it was over 7 in combination, that would fail as a DAIR. Somewhere around about 4 to 5 points was where actually there was more success rather than failure. But in fact, this hasn't been subsequently supported by other papers that aren't yet published, so it remains not to be fully validated. In terms of the hematogenously spread periprosthetic joint infections, there's the CRIME 80 score. Seems a bit ageist, but if you're over 80, you get 2 points against you. Interesting enough, they did include the exchange and modular components, giving you a minus score, so you can get -1 as a total score. And they also include COPD, CRP, rheumatoid arthritis, whether it was a fracture in male gender. And they again gave a score that was up to over 5, where it was likely to fail, and -1 where it was less likely to fail. So just bring a little bit on about the DAIR in the presence of sinus. This was a recent paper where they looked and demonstrated that sinus tract was associated with reduced survival of the joint replacement. But when they actually looked at the effect of modular exchange within that, the group, even with the sinus, actually came up to not much different to the ones with no sinus. And indeed, the modular exchange in no sinus didn't make that much difference. So it's the modular exchange that is really the key. And if you do that, you may well overcome the effect of the sinus. And as we are in the age of machine learning, various things have come out to try and predict DAIR success. And this is all stems from the consensus meeting that has been previously mentioned. These are predictable, the ones that you can put in information about the patient. I wouldn't say they're entirely reliable, and I would tend to go more by the information available from your MDT and discuss it with them, but it does give you a handle on what is likely to be a successful DAIR procedure or not. And from that, they've produced an algorithm, which basically goes down to if the implant is loose, you revise it, removing the implants. If it's well fixed, they do divide it into immune compromised, where you may consider just taking the implants out. If they're immune sufficient, hematogenous ones, less than 3 weeks, then you can consider doing it. They tend to use a CRIME score to divide it, but I would tend just to not put so much weight in these scores and go ahead and do the surgery. And similarly for the ones with an early postoperatively, you won't always have an aspirate available. The CLIC score they're using is 4, because that's where the sort of starts to be more or less successful. But I would tend to, if you're wanting to try and help that patient, go down more the DAIR procedure group. So just to sort of finish off, I'm going to do a couple of examples just to talk through hip DAIRs. So this was an infection at 2 weeks post a hybrid hip replacement. It's an 84-year-old, type 2 diabetes, essential hypertension, atrial fibrillation on apixaban, the usual healthy west of Scotland patient that we have. Osteoarthritis of the left hip with a previous successful right total hip replacement. So they were admitted at 12 days post-operative with a leaky wound on the apixaban. The anticoagulation was stopped. They were noted to have a rising CRP, so an aspirate was performed and grew an Enterococcus faecalis sensitive to amoxicillin. A DAIR procedure was then performed. At that point, the cup wasn't integrated, so it was removed, and there was membrane present behind it. And using revision cement with vancomycin, a cemented new cup was put in. On the femoral side, femoral neck osteotomy was revised with an oscillating saw, and then there was burying of some of the original cement mantle. And I think that's actually quite useful. Firstly, obviously to get the new implant down if you take the stem out, but also it does release local antibiotics and removes any possible biofilm in the proximal part of the cement. So it's something I think is useful to do. A new cement was then cemented down using revision cement again with vancomycin, and some extra stimulan with vancomycin and gentamicin deep to the fascia so it doesn't cause excessive exudate into the wound. And this was a post-operative appearance. You can see the cemented cup in situ, the pellets that are present of the osteocyte and the new stem down the original cement mantle. 1 week post-operatively, all intraoperative cultures grew Enterococcus faecalis. CRP was coming down. They were continued in IV vancomycin and changed to orals for a total of 3 months. So was this a DAIR or was it a one stage? The cup was removed, started with cemented cement, and there was a cemented cement in the femoral side. There was also stimulan put in periarticularly. But if you consider it a DAIR, they were 6 weeks later, a normal CRP, and at 12 weeks, the antibiotics were stopped. And at 1 year, the Oxford score was normal and the CRP was fine, and they had an adequate satisfaction score. So that was a successful case. And here at 1 year, but you can see there is some heterotopic bone. And the question is that from stimulan? Is that from infection? Again, these are the sort of things that the BAJIR registry in the future will hope to answer. So we then go to the next case. 72-year-old man, previous successful right hip again osteoarthritis of the left hip, routine hybrid hip replacement performed. 3 weeks down the line post-operatively, frank infection, but he'd been symptomatic for over 10 days. A liner exchange was performed and the stem was exchanged, and stimulant with vancomycin was inserted next to the prosthesis. Now, this shows the advantage of an MDT with infection ID and micro. They switched the vancomycin to level rifampicin as the cultures were negative. There was the issue of his anticoagulation and combining that with rifampicin. A score that most orthopedic surgeons wouldn't consider was used to consider going to edoxaban, which will have a little effect on the rifampicin level, so that had to be adjusted. So it shows the advantage of input of the MDT. However, if ever 3 weeks later, there was increased leakage again, the rising CRP, and view the previous cultures, no further DAIR was performed, but a one-stage revision. So this is actually a Kiwi technique with the cement coated around the prosthesis, having removed this original cement entirely from the femoral canal, and the original hemispherical cup was removed and a poorly cemented cup was put in. So it's a first stage revision. New advice, rifampicin didn't be required. They could stop the antibiotics at 6 weeks because it's a one stage revision. Question is, will we go in and do a second stage? The patient will be reviewed regarding that, but certainly a CRP is down to normal. Why did the initial DAIR fail? Well, I don't think that's as important as the decision-making process within the MDT to go on and look after that patient's care. So I think that's the important thing, that you have shared care of this patient. And why is that important? Because you as a surgeon are going to feel that you've had a moral injury when you get these infected cases of yours coming back. It's an elective procedure, it's unexpected, and we know they have poor outcomes. We're talking about re-revision and higher mortality of these patients as you follow them on in due course. And this was a patient that Mike Whitehouse from Bristol demonstrated how deeply affected patients are when they get these cases. And that brings back the support that you need to get from colleagues and the MDT, which will help you cope with this. Indeed, when we introduced an MDT back several years ago, there was no change in surgical volume, but the increased efficiency of obtaining micro and ID advice resulted in reduced lengths of stay of patients and an increased infection eradication. So in conclusion, the keys to success for DAIR are accurate case selection and timing of procedure, rigorous surgical technique, that is particularly exchange of any modular component, and that you are part and have access to an MDT for discussion of the further management of that patient. So with that, I will conclude and leave it open for some questions. And it would just be to re-emphasize that obviously that next year, the UKPJI meeting will be on the 1st of April at Glasgow Central Hotel in Glasgow. And I would really recommend all of you to come, because if anyone has an interest in periprosthetic joint infection, there'll be so many people that you can discuss things with there, and it will be very, very, very useful. Thank you very much.
Excellent, Dominic. That was absolutely brilliant. Thoroughly enjoyed your lecture. I can't see any questions at the moment from the thing. I would urge people to add any questions, please, so that we can ask the speaker any questions. Dominic, before I go, I would like to ask you, in case of hip, does DAIR increase chance of dislocation?
So DAIR will increase the chance to a certain extent in terms of debridement. There's not much in the literature about what sort of rate you're doing it, but because you're not usually changing the orientation of any of the components, even if you replace them, it's not huge, and you can usually counter that by maybe increasing head size, but it's certainly something to bear in mind and counsel the patient about.
That's great, thank you. So, questions. Can I ask what Adam Galbraith? Can I ask what duration of antibiotic therapy would you consider as suitable for a DAIR hip or knee?
Right. So that is something that you discuss with your MDT. In Glasgow, it's often 12 weeks, but there's certainly lots of evidence that some people use for 6 weeks. But as I say, you can't really dictate. It will depend a little bit on the organism and your local policies. So I'm not going to say it's 12 weeks, but that's what we use.
Excellent.
Tim's asking if I always change the tapered stem.
Yes.
And the answer is yes, I would if it's an easy exchange to do.
There is certainly something, there's a review article which was published. Does increase of component exchange alter the outcome?
Is what, sorry?
Does increasing the component exchange, say suppose cups, this and that, does it increase your chances of?
I think that's something that will come out again once we've got information from the BAJIR.
Right.
It makes sense, it will, because particularly if the more you change the biofilm and reduce that, and the more you access to get your lavage in and debride, it will make sense. But all we have at the moment is just saying that those who've had modular exchange have had a much better result rather than those who've had just wash out from that point of view.
Excellent. Pete, anything you can bring?
Yeah, I was just going to jump in. So there was a question from Mike Reed, just whether we really need to abandon the second DAIR. And I guess my follow-on question to you, Dominic, would be if you do have a failed DAIR, is that a two-stage revision in your hands for definite afterwards, or would you consider a single stage 2-in-1 Kiwi technique type? So
I think, first of all, with Mike's question, I think that again is something that in your local unit, if you feel in your hands a two-stage DAIR and you're auditing it and it gets good results for you, I think that's fine. I'm just saying that from the general literature that's around, it appears that it has to be in specialist, hyper-specialist units where they've had success with a 2-DAIR technique. Most people report that doing 1 DAIR and then doing another one tends not to work. I think it's a good question, but I think it's really going to be a very specialist unit that undertakes 2-stage DAIRs. And then, so your question is, would I go? No, I would consider quite often going to a 1-stage if it's, again, with discussion with the there is this aspect of, is a Kiwi spacer a 1-stage or a 2-stage? And obviously not in Scotland, but in the National Joint Registry, there's a lot of these spacers going in that never get a 2nd stage. And so in some ways they're a win-win, in that if they don't get revised, they're not a revision. And if they do get revised, they're not a revision because they're just the 2nd stage. So yeah, it's an interesting concept, but no, I think again, 1 stage is reasonable to do under DAIR if you've discussed it.
Excellent. There's a question from Deepu Bhaskar. There seems to be very little difference between DAIR, as just described, and a single stage. Where do you draw a line?
Again, a very good question. I think as we're getting more aggressive in our DAIRs, where DAIR is different is that removing a very well-fixed component that's causing a lot more damage, then that is where you draw the line with a DAIR. So if you've got an extensive porous coated cylindrical stem down the femur, you're going to have to do an ETO to get that out. You're going to do a DAIR in that. You're not going to do a 1 stage revision from that. So, but that was what I was really trying to illustrate with the first case, is that they're merging us into a spectrum really, and I don't think you can really be prescriptive in what it is. It depends on the components. It depends on how easy. The point of it is to do the least harm to the patient's whole soft tissues, at the same time get the maximum eradication of biofilm.
Excellent. Pete, any more?
Yeah, so there was a further question in. Question being, in your unit, would you use the same DAIR algorithm for revisions? So for example, the patient who's presenting with, say, 2nd or 3rd time surgery to that knee or hip, and they've now got revision components in, which are much more difficult to perhaps exchange. And would you still consider a DAIR in that situation? Yeah,
well, exactly. I mean, I think that was what was alluding to. Obviously, it depends a little bit what the revision was for. Yeah, I mean, I think these are exactly the cases where you would try and retain as much of the well-fixed material, but try and remove anything that is modular at all. But it would be certainly the same sort of algorithm you'd use for that.
Who would do the aspiration on first presentation and where?
Theatre. Under GA, you do an aspirate, and if you try and take a true cut biopsy as well, or a small open biopsy if necessary, and really that should be in the skill set of any orthopedic surgeon.
Excellent. Pete, any more?
Final question really is, where do you sit in terms of DAIR in the patients that the diagnosis is a little bit more difficult? So for example, their CRPs, not dramatically high, for example, or they've got a normal CRP, but clinical examination is very much in keeping with an early infection. Or the patients, for example, who have rheumatoid arthritis and it's very difficult to interpret their CRP. Do you still think a DAIR would be appropriate when you're not entirely certain about the diagnosis?
Well, I think these are the ones where you would probably do an aspirate for sure and take a true cut biopsy. Use some of the various bioassays that you can use to try and confirm whether it's infected. And in those cases, sometimes sending some of the material to pathology, even to see if you get a white cell count, just to give you some extra information on whether it is infected or not, particularly if they've been on antibiotics beforehand, so that giving you a negative. But I think these are difficult ones. And you would discuss them with your colleagues in the MDT before you actually proceed from that point of view. But these are not so obvious ones. But you would often hold back a little bit in those from DAIR because they're not obviously that unwell at that point.
Brilliant, Dominic, absolutely brilliant presentation and good questions and answers. I think, I know you've already answered 3 take-home messages. Could you please say it again so that that'll be quite good for the audience?
Okay, so first thing, so careful patient selection and the timing of that. You want to be less than 7 days if you can. You want to make sure that your surgical technique is thorough and it's modular exchange. Okay, exchange as much as you can. There's without doing damage to the patient. And finally, that's only the start of the treatment. Into the MDT, micro infectious diseases, they're the key to getting a successful DAIR.
Excellent. Thank you so much. Really appreciate it. Right.
Okay, thanks very much.
Pete, you would like to take to the next?
Yeah, brilliant. Thank you, Dominic. So I would just like to take a moment to introduce our next speaker. So Professor Mike Reid is a full-time trauma and holistically undertakes both hip and knee replacements in the Northeast. He trained in the north of England and undertook his fellowship training in New Zealand. He's previously been a co-author of the T&O curriculum, including involvement in the e-logbook, and has been a big part of the education committee for the BOA. At a trust level, he undertakes a significant number of hip and knee replacements. He's head of the department and he's the president of the British Orthopaedic Directors and sits on the Council of the British Orthopaedic Association. He's got a number of research interests, including national collaboratives on hip fracture care and basic science research in Newcastle University and clinical trials in the University of York. He supervises a number of MD and PhD students and also is undertaking several large multi-centre studies. He's on the steering committee and the executive of the National Joint Registry and chairs the annual report. Professor Reid's going to talk to us tonight about something often overlooked in prosthetic joint infection, and that's the patient perspective following what is essentially a devastating diagnosis. And where cancer services have psychologists, nurse specialists and patient support groups, in spite of PJI actually having a worse prognosis, we have none of these adjuncts. So Professor Reid's going to talk to us about starting a patient group for prosthetic joint infection. Professor Reid.
Peter, thanks so much for that introduction. I feel very guilty actually, because the main event tonight is Nigel Westwood, who will tell us a patient story, and I think really will steal the stage. I will say a few things afterwards, but I really wanted to introduce Nigel, who I, excuse me, I first met hearing his story some years ago. So he was a naval officer for 25 years, was commanding ships, and was also when he was on land, was in the sort of command and control arena of the Navy. And then he had to retire on ill health, and we'll hear a little bit more about that. He now runs his own IT company and volunteers actually for several charities, particularly with patient support groups. And he also works for NICE and other agencies as a lay member, so is extremely busy now on that sort of activity. When he's not doing that, you may have seen him at Stonehenge showing some of the, talking about some of the history there. So Nigel, I'm going to just bring you to tell your story. I'm very grateful for your time this evening.
Thank you, Mike. Ladies and gentlemen, good evening. As you just heard, I'm Nigel Westwood. And for the next few minutes, I would like to tell you something about the impact of a surgical site infection on the patient, and then tell you about some work that has started in an attempt to quantify the patient issues related to an SSI. While not specifically related to bone or joint, I had a substantial SSI a few years ago that had an enormous impact on my life. I was, as you've heard, a highly regarded commander in the Royal Navy. I was attending the Joint Service Defence College in London on a course that's for those destined for the higher military ranks, and I had already been in command of a ship at sea for over 2 years. One morning I woke up with what I could only describe as an incredible sense of urgency, and deposited a substantial quantity of blood in the toilet. And after a lengthy diagnosis process and many months of intensive drug treatment, culminating in my developing pyoderma gangrenosum and becoming a steroid-induced diabetic, it became clear that I had no option but to have my colon removed. I left the Royal Navy shortly after this surgery, when it was made absolutely clear to me that I could not go back to sea nor serve abroad, and that I would not be further promoted. While the loss of my career and income and the formation of a stoma came as a considerable shock to my body image and to my bank account, I was able to get on with my life. In general terms, things were going quite well until about 5 years later, when I woke up with all the symptoms of a blocked stoma. It became clear over the next few days that I did not have a straightforward blockage, but a strangulated parastomal hernia and a ruptured Meckel's diverticulum. I spent about 8 hours in theatre, having around 1 metre of small intestine removed, the peristomal hernia repaired and strengthened with the mesh, and my stoma moved from my right side to my left. I woke up in the intensive care unit where I stayed for a few days before moving to the high dependency unit for a few more days and then back to the ward. About a week later, my temperature increased considerably and I developed a discharge from my midline incision. A scan established that I had an abscess on my old stoma site that was too deep to deal with under a local anaesthetic. So I went back to theatre for what should have been, I'm told, a 20-minute operation to open it up, wash it out and dress it. I was returned to the ward about 2.5 hours later with 2 large open wounds. The first open wound was my previous stoma site where the abscess had been drained and washed out, and the second was a much larger wound where they had reopened my midline incision. My rectus abdominis was either destroyed by the infection or abrided away to deal with the necrotic and infected tissue. This wound was about 20 centimetres up and down and around 15 centimetres wide and about 4 or 5 centimetres deep. And just to cap it all, my diabetes, which I had been controlling with tablet and diet, went haywire, and I've been injecting insulin ever since. It was at this low point in my life that I was introduced to vacuum-assisted closure therapy, which required me to have a large sponge carefully sculpted to fit my wound being inserted into the cavity before I was wrapped in sticky back plastic with a vac therapy machine connected up to reduce the air pressure in the wound and to suck out wound exudates. This therapy allowed me to go home after only 9 weeks in hospital. I continued to use the vac therapy at home for about 3 months with visits to the tissue viability clinic every other day for my wound to be checked and the dressings changed. It took about that 3 months for the wound to come down to a size and depth that required a different form of dressing, but overall it took around 2 years for the wound to fully heal. A wound of this type has a significant impact beyond just the physical with the patient. When I first saw it, I would have to tell you that I very nearly passed out. My blood pressure dropped like a stone. I became grey and ashen and started shaking and sweating. For the next 3 or 4 dressing changes, I very carefully held a towel up between my eyes and the gaping wound in my abdomen just to stop myself looking. I was genuinely worried that if I stood up, my insides might fall out. I know now that it was a foolish worry, but at the time it seemed like a very real possibility. Over time, you get used to just about anything, and after a while I was happy enough to look at the wound, which I have to tell you brought a whole new dimension to the concept of navel gazing. While the wound itself was reasonably straightforward, my stoma proved to be a serious complicating factor, as it was only about 1.5, maybe 2 centimetres from the edge of the open wound. And this led to some problems when applying the vac therapy drape. Should it go over the flange on the stoma bag or under it? The choice was to accept that my stoma bag either didn't stick well or that it leaked directly into the wound. I have recovered from the SSI, but I am now facing the probability of substantial surgery to remove the large area of scar tissue in the center of my abdomen and to reconstruct my abdominal wall. I understand that this procedure would involve removing the scar tissue, placing a mesh right around me, separating the layers of my oblique muscles and moving them around to fill the hole on my center line, and then repositioning my stoma before closing me up. I'm told that it would be a planned intensive care operation and that it is likely to take me between 9 and 12 months to fully recover. The surgeon has also told me that the fix will, at some point in the future, fail, but I might well have died before that time happens. In honesty, I'm not entirely sure that I want to undertake this surgery, as there are significant risks, and I may be no better off afterwards if it fails quickly. My wife and I have not yet made the decision that I need to know more about the risks of not doing it as part of that decision-making process. And this opens up another aspect of a surgical site infection. It doesn't affect just the patient, but their family too. In my case, I was left unable to work for around 12 months, and I have to tell you that self-employed people don't get sickness pay. I could not support my family. I ran up considerable debts and mortgage arrears. There was a huge sense of failure and uncertainty about what the future held and my direction of travel. It really was a dreadful time in my life, which I am thankful is now behind me, although the spectre of that further surgery is of course still hanging over me. As a result of my experiences, I feel quite strongly about the need for a patient support system for those suffering an SSI. At the time, I could find no support to speak of, and I don't think that that situation has changed much since then. Over the last few months, I've done some work with the Cardiothoracic Interdisciplinary Research Network, following a presentation I did for them on the impact of an SSI. Like BAJIR, they are also interested in a patient support network of some description. The suggestion at present is that the best way forward is to provide patient SSI support generally rather than a number of topic-specific groups. Initially, we'd want to develop an online questionnaire to see how much demand there is for SSI support from patients and from their carers. A charity that has worked with the Cardiothoracic Interdisciplinary Research Network in the past has agreed to help with developing the survey questionnaire and analysis of the responses received. Once the questions are fully developed, the plan is to reach out to patient and professional groups and ask that they send out details of the survey to as wide an audience as possible. Overall, the concept is that support for dealing with an SSI in any particular surgical area should be provided by the patient support group dealing with that area generally, but that there should be a web-based application as a front end that allows visitors to filter their way to the support group most applicable to their particular topic area. The first step from our perspective is to understand where the high demand areas may be and how much demand there is from patients for such support. The proposed questionnaire should achieve this. I would like to ask people if they've had an SSI, when they had it, where was it, do they have ongoing problems with it, how supported did they feel, where did any support received come from, and what additional support would have helped them at the time. Ultimately, the hope is that the support groups can assist research into SSI issues by developing common themes and understanding support needs. But I think it is important initially to develop patient trust by providing information before asking for further details or involvement. Assuming this work pans out the way I hope it will, then there will be need for patients to be supported in many topic areas by the owner of that topic area. And that will require significant work by BAJIR to offer patient support around bone and joint infections. Ladies and gentlemen, I hope that I've given you a brief feel for the impact an SSI has had on patients and particularly on their families, and provided an introduction to the work we would now like to progress to quantify these issues and to help patients affected by an SSI. Thank you.
Nigel, thank you so much for taking the trouble to come this evening and tell us that story, which I think will touch everybody. And of course, Nigel didn't have a bone and joint infection, but he did have an equally devastating problem. And I think we all know patients who have essentially had their lives ruined by periprosthetic infection. And I think, as Nigel described, we all know patients who really didn't feel they had anywhere to turn to, anyone to turn to help them with their problems. And I think, you know, this is a massive gap that we have in our community. So Tom Partridge is one of the senior registrars in the Northeast, and for his MD, he did a focus group talking to patients with complications. Actually a very brave thing to do. He essentially did a focus group with patients that didn't have complications, then a separate one which was full of patients that had complications. And I was asked to provide some patients of mine that had, and my colleagues were. And I think a really unique piece of work where they were all in the same room expressing what they thought. And I think, you know, preoperatively, they had the same thoughts as many patients were. You know, they were limited by pain, and it was really the loss of control they suffered, which was the main issue preoperatively before their joint replacement. They were reassured, having spoken to their surgeon, and postoperatively they wanted pain relief, and success was their key priorities. if you look at the group then that actually went on to have a complication, this was really the themes that came out of that thematic piece of work that Tom Partridge did. And I'm not going to go through all of these, but you'll see that, you know, patients were angry, frustrated, disappointed. They were very upset that pain had returned. They were limited in their activities. Some of them carry a huge treatment burden. And I think Nigel just put that very, very, very clearly about the treatment burden that he carried and actually still carries. Interestingly, the patients did accept the risk. They knew about it up front, although I think probably many of us feel they hadn't fully considered the consequences of that. And these are just two quotes from people that had infections. This group actually had a whole range of complications, but some of them were infection. So I think we do really, as a community, have a duty to try and improve things for patients when they have this terrible diagnosis. And certainly when I've spoken to people on our bone infection unit, they're experiencing a very significant number of problems. And the financial ones that Nigel mentioned are also very commonplace. So I wonder if just you could help us out. We're not going to discuss this further this evening, but if you could put in the chat what you think the key concerns are for your patients that do have a bone and joint infection. That's really just to help us determine the sorts of resources we might make available for patients. And, you know, that might be finances, but it might be lots of other components. I know the smell of an infection is a concern for quite a lot of our patients, as well as all the ones you'd expect, like pain, etc. So if you're able to put your ideas in the chat, that would help us significantly. And then secondly, are you aware of any support group for patients with PJI for fracture-related infection? And please put that in the chat as well. If there are other groups sort of currently operating, then we would probably want to put our energy behind them rather than reinventing the wheel. I'm certainly not aware of any groups that are doing this at scale for right across the country to help patients. So this is just a plea, really. I think I would just hope that you can help Nigel on his quest with this, with disseminating the survey that he's creating, or the team that he's working with is creating. You know, as stakeholders, we'll be able to hopefully send that on to patient groups and also professionals, if you want our opinion on that, Nigel. We will seek funding for a specific PJI or fracture-related infection group, potentially the same group. I'm hoping to get an educational grant for that small amount of money needed, probably about 5K, that would set us up, providing some resources. As Nigel says, he thinks the best way to draw patients in is to provide them with some information, if you like, as our opening gambit, and to help people. Nigel has kindly agreed to support us as we launch that, and he's got a lot of experience with that in other disorders. And eventually we'd need to become sort of self-policing and running this ourselves. But I think having the experience of Nigel would be really, really helpful. So we will keep you informed. And finally, if anybody in the audience is keen to help us with this project, then we'd be, or at least I'd be very keen to hear from you. That's my contact details. We've had several plugs for the Bone and Joint Infection Registry this evening. Thank you, Dominic. And we'd love to hear from you also if you're keen to join that. Either contact me or on the BAJIR.org website. We'd love to be in touch with you. And that's all I have to say. So I'll stop sharing.
Thanks, Mike. Absolutely brilliant. Actually, I think when you think about infection, a lot has been published on effect on hospitals, resources, effect on doctors, etc. But about patients, I think the information is clearly lacking. I think excellent piece of work. Pete, you want to?
Yeah, it was just really to say thanks to Nigel for sharing his story, and to Mike as well. I think this is an area that's very much under-resourced and forgotten about, really, in bone and joint infection, and certainly something that we should really be pushing towards and trying to get money. You know, as we said at the start, when you think about how much money is put towards this sort of thing for patients who've been through ICU or patients who've been diagnosed with cancer, you know, we have a fraction of that sort of funding for patients who are in a very similar situation, really. One question I had for you, Mike, actually is, you know, how do you think consent fits into this preoperatively? So for your patient who's never had an SSI, how do you consent them to understand the impact? You know, Nigel obviously knows firsthand what this is like, but patients, how do you explain to them before they undergo surgery?
So of course it's really tricky when you've obviously got a sort of restricted amount of time to discuss complications with patients. So the one I use, which I don't feel is too dramatic, is that if you do get an infection, it'll ruin your life, and that's the words that I use, and I think that's probably about right, because it is really devastating when it happens. But I don't know. I mean, I genuinely don't know what others feel, and that's not evidence based.
Thanks. And to Nigel, I mean, is there anything that the surgeon could have said to you beforehand that would have perhaps changed your mind about surgery, or do you think there was any other way that?
Well, in honesty, I was in a no-choice scenario. If I didn't have the surgery, I wouldn't be here now. So from my perspective, it had to be done irrespective of the risk in many ways. I mean, I was in a very serious position, and because I was initially admitted to hospital on a Saturday, which, without being rude to hospitals, is potentially not a good day to be admitted to a hospital, and the duty surgeon agreed that, you know, it's probably just a blockage and it took until the Monday mid-morning really before you know, the experts turned up and started prodding me and poking me to decide that it was a lot more serious than that. And I was told that I would have to go down to theatre quite quickly. I had a scan, and I went to theatre within about 45 minutes of the scan results being looked at. And there wasn't a lot of time, to be honest, for the surgeon to tell me anything about what they were going to do or what the potential risks were and all that sort of business. He did take the decision to phone my wife and tell her that he felt that she ought to come into the hospital because I might not come out at the other end of it, which was quite an interesting, you know, sort of shock to the system generally. But I was really in a no-choice scenario. I mean, I work now with NICE, and I sit on the technology appraisal committee, and I kind of joke with people from time to time that I sat as well on a number of guideline development committees, including medicines optimization and the one looking at consent and how we get consent going and informed consent and all that sort of stuff. And I've always said, in an emergency situation, I don't want you guys asking me what I want and you know, do I understand the situation? If it's an emergency, fix it. It's the non-emergency situations where I think, you know, there's more opportunities to go into detail with the patient. So it's a very difficult situation. I think consent is a difficult one. There are certainly some patients that won't be in a position to give you consent at the time that you're starting the surgical procedure or whatever. And there will be other patients who actually, you know, don't care what you're going to do, just get on with it. You know, I mean, I think some of it is generational. I mean, certainly my father would have believed categorically that if the doctor said you need to have this done, then he would say yes, sir, and have it done. And he was shocked when I was in the military in that I was senior in rank to my doctor, and he couldn't understand that my doctor called me sir. That was completely beyond his comprehension. So there is a generation issue as well. But I think consent is a difficult area, but certainly in my case, it was a no-choice scenario.
Absolutely.
Thanks for that. I think that's us just a little bit past 9 o'clock, so we'll probably wrap up this final webinar. Many thanks to Dominic for talking to us about DAIR, a fairly controversial area overall. Many thanks to Mike and Nigel for again sharing that patient perspective and the importance of remembering there is a patient at the end of the PJI. And thanks to all of the other speakers over the last 3 or 4 webinars. Just a final plug that the conference itself, face-to-face, will be on the 1st of April 2022 in the Glasgow Grand Central Hotel. If you want to go to ukpji.com, all of the information should be on there within the next month, and you should be able to sign up as well. So just once again, many thanks to Dominic, Mike and Nigel for their time, and also many thanks to the industry for their support with the financing of this, to David Shields for his organisation of the webinars, and Bilal, and to you as attendees for giving up your time tonight. So once again, many thanks everybody, and good night.